It's really my absolute pleasure to moderate this round that will be presented by Dr. Norah F.AlKhereigi. Dr. Norah F.AlKhereigi is our corneal consultant at King Saud University Medical City. She graduated from King Saud University and she did her training in the joint program between KSU and KKH. Then she did her fellowship at KKH years. I had the pleasure to know Dr. Norah F.AlKhereigi when she was in training. She's really a person and a skillful surgeon, and I can't wait to hear her talk on corneal cross-linking. Dr. Norah.
يعطيك العافية دكتور ماجد ما قصرت. Thank you very much. Thank you, Dr. Majid, for this introduction. Thank you, Dr. Huda. I hope the seminar on Saturday will be a great success. And I would like to also congratulate Dr. Huda on his excellent presentation. So we'll be talking today about corneal cross-linking. I wanted to address this a bit different. So I wanted to go back to the basics of cross-linking and just and revisiting the biochemical aspect of it, just to get that deep understanding of cross-linking. And then we're going to talk a bit more about the corneal cross-linking itself, more about the protocols and addressing thin corneas. And then we're going to address specific situations. Of course, corneal cross-linking is a very, very wide topic, and each aspect of it has its own diverse and very wide areas of discussion. But I will focus in the areas where I think maybe we need to just highlight a bit. And inshallah, maybe somewhere in the future, somebody will continue the rest of what needs to be said. So going back, really back to cross-linking itself. So what happens in cross-linking? It's actually when you take this amino acid, the simple amino acid, and when it first is created, this central protein backbone has many residue. And these residue have the tendency or undergo actually lots of modifications throughout its existence. The main modifications that happen, I'm sure many of you, if you just dig back behind in your memory, you remember the terminology translations. And many of them include phosphorylation, glycolization, and one of the most important modifications that happen is cross-linking of these residue side chains. So protein cross-linking is basically forming covalent bonds. Sometimes these bonds start non-covalently and then they form into covalent bonds, one or more. And these covalent bonds, they are the main area of interest of this cross-linking process, and it binds the two particles together and forms really that bond and keeps it together and creates this new network of these macromolecules. So there are many types of cross-linking. Maybe this is not such a relevance to us, but it's important just to know in general. There's the inter-peptide cross-links, and this is the strongest form of a cross-link between the proteins, and it happens between two molecules. And you have the intra-peptide, where you can see it here. Sure, I can see myself. Yeah, so you can see it's in the peptide itself, and then you have the dead end links, which is the weakest, and you can see how it's just hanging there, waiting to be attached to another molecule. So how do we induce this cross-linking process? It happens if there's a stimulus or an insult of some sort. Many of the industrial or natural cross-linking processes happens through a physiochemical reaction or insult or trigger. It could be heat, it could be an alkali condition or environment, could be related to mechanical agitation, or in our case, in cases of cross-linking, a photooxidative or a photochemical reaction that happens. Chemical reagents as an inducer of cross-linking happens either enzymatically or non-enzymatically. And the two regions of the physiochemical and the chemical reagents, sometimes they overlap and work together. So this is just a pure physical cross-linking that happens. So it starts non-covalently, and this is not such a strong link. So you need that chemical component just to make it a covalent bond, and a much tougher bond between the molecules. So you have that firm network when you are producing something new or creating a new situation for the protein. I would like just to give you, other than the corneal cross-linking that we know, just another realistic biological example that happens to all of us. So there are lots of enzymes in the body, the transferases, the transglutamases, and they all induce cross-linking, and they catalyze formation of lots of molecules. One of them is the glutamyl acyl isopeptide bond. And this is one of the examples of these enzymes, the fibrin stabilizing factor 8. This helps in blood coagulation by inducing the cross-linking of the parallel or anti-parallel fibrin chains. So what does this mean? It means that when you have bleeding from a wound and you develop that clot, what makes that clot even more mechanically stable is these cross-linking processes and these covalent bonds that form and that strengthen your wound. Strengthen that clot just to keep it in place. This is what happens, and you can see that fibrin here gets cross-linked, and then you have this insoluble clot which is mechanically stable. I want to talk a bit more about the photoreactive or the photochemical cross-linking process. And this is an area of interest for us because of the corneal cross-linking process that happens that is dependent on this kind of reaction. So first of all, these kind of cross-linking reactions are very dependent and induced by exposure to light, to the UV light. And these reaction or this induction, it happens usually by the help of photoreactive agents or photoreactive inducers, such as we'll talk about them a bit later, the flavins, which need to be highly reactive and very stable in the dark and resistant to photolytic damage, because if they are photolyzed by the light, they're gonna deplete very quickly. So in corneal cross-linking, which was introduced in the late 1990s, the main indication or the main interest when we're talking about corneal cross-linking was because of keratoconus and its ability to hold the progression of ectasia in these eyes. And you will notice throughout the presentation, all the protocols and the set of everything that's being discussed is mainly related to keratoconus because it's the main interest for corneal cross-linking. So as I mentioned just a moment ago, it's a photochemical reaction that happens. And what happens in the cornea is that new covalent bonds between the collagen fibers in the stroma, as well as many side chain bonds occur also between the proteoglycans and the extracellular matrix. So this whole process of bonding, this cross-linking process that happens, we said the first thing that happens is the UVA light. But in order for all this process to happen, you need also, I just want to emphasize on two extra points: the presence of the inducer, which is the riboflavin, and the reactive oxygen species. So all of these three components are quite crucial in the cross-linking process, and we'll break some of them a bit more in detail. And again, I just want to emphasize these covalent cross-linking bonds are quite rough and tough, and really are able to increase the rigidity and stiffness of the cornea. Now for the flavins, let's talk a bit more about the riboflavin. So the riboflavin, sorry. So the riboflavin is part of the flavin group, and the flavin basically, or flavus, means yellow, and these are thermostable and photosensitive. So these flavins that are thermostable, they need to be thermostable and photosensitive. Um, they, as I mentioned, because if they have this photolytic tendency, they're going to break down and deplete very quickly, and you won't get the effect that you need. One important characteristic of these flavins is that they allow for the changes to happen in a short amount of time. So the reaction is quite fast and speedy. So flavin is from flavus, yellow, and you can tell just by the color of your riboflavin fluid. Riboflavin, which is the most naturally occurring form of riboflavin, which is the vitamin B2. You can find it in lots of, food supply. It's the primary inducer that is used in many of the photochemical reactions, not just for corneal cross-linking, for other cross-linking processes that are dependent also on the photoreactive, stimulation. The structure of this riboflavin, the alkyl isoleucine structure, allows absorption of a wide range of light spectrum. And we're saying this because we need to know that riboflavin has two absorption maxima, so two peaks where it really, reacts to the UVA light at 300 and at 370 nanometers, and one in the visible spectrum, the blue region, at 435 nanometers. So why are we always using the 365, 370 nanometer, wavelength? Why? Because it provides the best combination for absorption and for safety. So safety is quite crucial here, because when we are using the 300 nanometers, this is actually harmful to the cell DNA. And if we choose to go to the spectrum of the blue light, this could be potentially damaging to the retina. Before proceeding, because I know it's probably a long presentation, I just want to point out some things while we go and revisit them later. I just want to talk about, so the riboflavin is quite important, inducer to be present in this photochemical reaction of cross-linking. So this is important. Why? Because the process of cross-linking, some protocols, they call for an epithelium on or transepithelial technique. So when you keep the epithelium and don't remove it, this hinders or reduces riboflavin absorption and penetration into the stroma. And by that mean, it will reduce the efficacy of the technique. So this is just, I'm just emphasizing how important the riboflavin is as an inducer for this photochemical reaction. It needs to be present really, really soaked and well present in the stroma of the cornea, so that it can give you good, cross-linking response. If you have anything that will obstruct the penetration, such as in the epithelial on technique or transepithelial cross-linking techniques, then the efficacy of this whole procedure is greatly reduced. Now, so we talked about the UVA light, we talked about the riboflavin. The third component, which is important in the whole process of cross-linking, is the oxygen. And the oxygen is important because when you have this photosensitization process and this reaction that is happening, the whole process, it induces and produces a singlet oxygen, and this singlet oxygen, which is basically a simple O2, this reacts with the collagen fibers and the proteoglycans and induces these covalent bonds. So including also tyrosine residue in the stroma. So all of this is really quite dependent on the singlet oxygen that is, produced when the catalyzed reaction happens. So if we want to summarize, we'll say that the ultimate rigidity is dependent on oxygen. So by general theory or concept, if you increase the concentration of this oxygen during irradiation, most likely you're going to have an improved efficacy of your cross-linking. And from here came the concept of pulse techniques in the cross-linking machine. You can set it on a pulse technique where you allow for some oxygenation. And the idea is because as I just mentioned, oxygen is really important in these covalent bond formations and in getting a rigid cornea. With that being said, photochemical reactions in cross-linking actually happen under aerobic and anaerobic conditions, okay? But the aerobic conditions, which is in the presence of oxygen, the type 2, is the one that gives or yields, the singlet of oxygen and gives you the good covalent bonds that you want in order for the corneas to stiffen. But anaerobic type 1 conditions or type 1 reactions also happen. So in type 1, it's an anaerobic condition, and it happens to riboflavin. It's taken as a substrate, and then free radicals, oxygen-free radicals are induced by photolysis. The second or type 2 reaction, anaerobic, which is the more important component of the reaction, this is the part where the singlet oxygen is produced, and then you can have the photooxidation of the stromal proteins and the covalent bond formation. So oxygen depletion, when does it happen? So initially we assume there is oxygen, all over the place. But actually what happens is that oxygen is depleted quite quickly within the first 15 seconds of UV initiation. So when you start that light, 15 seconds within, all the oxygen in that region is depleted, okay? So when you turn off the light, there is rapid replenishment of oxygen. And from here, the concept, as I mentioned before, the pulse technique is just to allow the replenishment of oxygen when you, put the UV light off, and then you'll have the few seconds on and then off and then on, just to allow, that good concentration of oxygen to get the best possible outcome of these covalent bond formations. So this is the reaction itself. So what happens to the cornea when you're cross-linking? There are lots of structural changes. We'll address some of them, starting first with the initial change of thickness, as to say, in the cornea. And this is related to the hyposmolar or isoosmolar riboflavin solutions when you first place them. So it induces some changes because of the hydration, rather than cross-linking, effect itself. It's because of the hydration of these fluids. So this is the first thing that happens. The second thing, which is the major, striking phenomena that happens while or during the process of cross-linking, is there is lots of apoptosis. The apoptosis happens because of the UVA light and because of the riboflavin. And because they are together, this intense apoptotic process is seen during cross-linking, and it's usually in the anterior stroma to begin with. The peak of this apoptotic process occurs in the first 24 hours after the procedure. We have to know also that like any case scenario where the epithelium is scraped, there is apoptosis again in the cells, but it usually happens 4 hours after debridement, and it's usually a lot less milder. So there's, there is apoptosis, it's a lot milder and more subtle compared to the apoptosis that's happening from cross-linking. And the depth of cell death is proportionate to the total dose or the total fluence and the time of irradiation. So the higher the total dose that you are using, or the higher irradiation time that is there, the more apoptosis and the more reaction and the more cell death that is going to happen. Something to know also, it's quite interesting, is that riboflavin actually increases the UV light absorption in the corneal tissue. So it increases the UVA toxicity and potential toxicity from irradiation compared to just UVA alone. So that's why the combination of these two together really induce the the aggressive keratocyte apoptosis that we see post cross-linking. Looking at the confocal microscopy, it was noticed that there is a significant decrease in the density. So the confocal microscopy studies have showed that there is a significant decrease of the anterior stromal keratocytes that continue to happen up to the first 6 months after the procedure. But by 1 year, usually this cell density starts to, gradually come back to the normal values. This is, of course, for both any form of cross-linking, whether it's standard or accelerated. Also, replenishment of some of the newer keratocytes can happen or start from the 2nd and 3rd months after cross-linking. And as you can see here, you can see how the cells, this is initially after cross-linking immediately, and then you can see here some cells start. This is at, I think, this is at 6 months, and this is at 1 year, and this is at, I think, it was a year and 4 months. You can see how the keratocytes really start to build up in the stroma. One of the major losses that happen initially after cross-linking is the loss of the sub-basal nerve plexus. And usually all this, it starts to get restored and return back to normal by 12 months after the procedure. And that's why, corneal sensitivity is not that much reduced to an extent where you have, neurotrophic kind of situations and recurrent erosions, and all of that from cross-linking. Usually doesn't happen as a, long-term side effect of cross-linking. So this is what happens. So you can see here the collagen fibers, they're quite away from each other. And this is after, when all these lots of new covalent bonds have formed between the fibrils, and you can see how they're all put together and just, compressed with each other. Now the protocols of cross-linking. So after, now we just finished the, the basic concept of cross-linking in general and corneal cross-linking. I would like to just go through some of the protocols that are out there. So the 3 main epithelial off protocols are the standard or resonant or conventional protocol. And then we have the standard accelerated or accelerated with equivalent total irradiance. Or you have the increased accelerated, or we call it accelerated with increased total irradiance. And when we're talking about the epithelial off technique, usually when we're comparing the techniques, the standard or conventional protocol usually is compared to the increased accelerated. So usually we're comparing the Dresden protocol with the high fluence accelerated protocol, where the total energy is actually higher. So these are the 2 techniques that we are usually comparing, in studies and articles. These are the ones that we are usually discussing. Other techniques or protocols is the epithelial on or transepithelial technique. And then there are a couple of ways to deal with cross-linking in ultra-thin corneas or thin corneas in general. And then we have, a specific situation where you have the cross-linking with photorefractive surgery. So in the epithelium off techniques or protocols, the reason we, these accelerated ways of cross-linking the cornea have been, studied and utilized is because of something called the law of reciprocity, the Bunsen-Roscoe law, which basically means that, or talks about when you have basically a photochemical reaction, there is some form of reciprocity between the irradiance and between the exposure duration over a range of time. So if you substitute, so for example, if you have a specific amount of irradiance and use it on long, so you have a low dose of irradiance and use it over a long time, the result should be equal to having a higher irradiance with a shorter time. So this is what this law of reciprocity is talking about. Though in practicality, what many studies have found is that that doesn't really apply all the time. So sometimes the expected effect that you assume will happen doesn't really work the way this law has mentioned. But in general, this is the law of reciprocity, and this is why you have these three forms of epithelial off techniques, the main three forms, and just it's a matter of adjustment of irradiance, amount of power, and the time and duration, and how we're manipulating all of this to get some results. So the standard or the resent protocol, this is the first and original protocol that was described, also called as the conventional protocol, and it's described by William Sack and his colleagues. And the main target or reason for introducing these kind of protocols was for keratoconus. So all the measurements that you're seeing in front of you is just directed to when you're dealing with keratoconus patients. So in the conventional protocol, just take you through some of the steps. The first step is epithelium is mechanically removed, and this is quite important, especially removing the epithelium so that you have good coverage or exposure of the cornea. So the average that we're doing is at 9 millimeter corneal diameter, but you can go from 8 to 10 millimeter. After that, what we usually do is check with the ultrasound pachymetry and check the corneal thickness. It should be more than 400 micrometers, and we'll talk about the safety margin a bit later. And then the riboflavin uses the Hyposmolar with the 20% extract. You place a drop every 2 minutes for 30 minutes. And this should be enough soaking time so that the cornea is really saturated with the riboflavin and you get the good result of the UVA light. The corneal stroma and anterior chamber saturation that can be actually confirmed by taking a slit lamp and just examining. You can see the dye or the color of the riboflavin, seeping into the all of this up to the anterior chamber, and by that you know that you have enough saturation of the riboflavin in the cornea that allows you to go to the next step. So after this process, after all of this, then you just align the cornea, and depending on what machine used, usually the original machine that was being used for a long time is the PESCA machine, and it gives you a UVA of 370 nanometers. And in the conventional protocol, the radiance is 3 milliwatt per centimeter square, and this is exposed on the cornea for 30 minutes. Okay. While you are exposing the cornea to the UVA, you can reapply the riboflavin every 5 minutes. The total fluence that we want to get is the 5.4 joule per centimeter square. The next protocol is the standard accelerated, what it's called, or the accelerated with the equivalent total irradiance or with the equivalent fluence. So this protocol, it's very similar to the present protocol. And you start with the epithelial mechanical removal, you check your tachymetry, your ultrasound, and then you use the Vibex solution, which is just the 0.1% solution of riboflavin. And this is instilled over the cornea every 2 minutes for 20 minutes. So the soaking time is a bit less because it's there's no dextran, it's just the riboflavin. And then you just align the cornea and you expose it to the UVA light. If you're using the Schwind machine, it gives you the radiance of 365 nanometers wavelength. And the irradiation in the standard accelerated protocol is 9 milliwatt per centimeter square for 10 minutes. This is, of course, we are talking continuous, not pulsed technique. So this is a continuous 10 minutes treatment. And again, you can apply the riboflavin every 5 minutes. The total fluence or the total irradiance is 5.4 joule per centimeter square. So the standard accelerated and the standard conventional or the resident protocol, they both have the same total fluence. The difference is in the irradiation. So I'll just repeat what I said in the accelerated with the equivalent total fluence or total irradiance, which is also the standard accelerated. So it's basically the same process as the standard conventional, where you have the epithelium that is mechanically removed at 8 to 10 millimeter. As I mentioned, usually many of us are using the 9 millimeter corneal diameter, size. And then we go with the ultrasound tachymetry just to make sure that the corneal thickness is 400 micrometers and above. And then we use the riboflavin without the dextran, so it's 0.1% solution. And because of the nature of the solution, we just instill it for 20 minutes, 2 minutes, every 2 minutes for 20 minutes. And that should be enough to saturate the cornea well. The cornea is then aligned and exposed to the UVA light. Typically, what is used in this protocol is the Schwind machine, and this uses a 365 nanometer wavelight with an irradiation of 9 milliwatt per centimeter squared for 10 minutes. And I think what's important to know here is in the protocols that I'm mentioning, because they are, the standard description for the protocols. They are described as continuous, okay? But depending on the machine you're using, you can make it pulsed if you up to, which is better, of course. So this description is for continuous cross-linking process. It's not pulsed. And then also like the standard procedure, you can use riboflavin if you apply it every 5 minutes interval. The total fluence is 5.4 joule per centimeter square. So if you look at the standard conventional and the standard accelerated, the total fluence is the same. It's 5.4 joule per centimeter square. But the difference is in the irradiation and the time. So in the standard conventional, the irradiation is 3 milliwatt per centimeter square for 30 minutes. In the standard accelerated, the power is higher, and so the time is lower per the law that we described, the reciprocity law. So it's 9 milliwatt per centimeter square for 10 minutes. So a higher power with a short duration of time. Comparing both these protocols, they both gave the same efficacy in regards to the outcomes post cross-linking. The last protocol from the epithelial off technique is the accelerated or the increased accelerated, or the accelerated with increased total irradiance or total fluence. And this is the term when you hear comparing, the standard versus accelerated, usually they mean the increased accelerated. So usually they are talking about it's always good when you're looking at the literature and you're reviewing cross-linking, or you're just exploring what kind of crossing process you're going to apply is just to make sure that what kind of irradiance are they talking about in the time, because and the total energy that they're talking about, because in the increased accelerated it's a bit different from the standard accelerated, because the total fluence here is a lot higher. So you go through the same process, you remove the epithelium, you apply again the riboflavin, no dextran, in the Vibix rapid formula from Avidju. This is the most widely famously used. And then you can instill this for every 2 minutes for 10 minutes. And then after that, you check your pachymetry, you make sure it's above the 400 mark. And then you can rinse and start your UV illumination process using the Avidju machine. This is the most, I think, widely used machine in the increased accelerated or the accelerated with the high fluence. So the irradiation that's conducted here, it's quite high. So the energy is high. It's 30 milliwatt per centimeter square. So it's a lot higher compared to the standard conventional, which is 3, and the standard accelerated, which is 9. And because this energy is high, the amount of treatment is, or the duration of treatment is short. So it's 4 minutes only. And as I told you, because we're describing the standard protocols, it's all continuous. You can opt to go for a pulse, which is better always. And the total energy now that you're getting with this is 7.2 joules per centimeter squared. All these protocols are effective in halting the progression of keratoconus. Okay, and the concept and the proportional difference between the energy and the timing is all based on this Bunsen-Rasko law or reciprocity law. And as I told you, in these 3 protocols at least, it did show to be valid, but in some case scenarios, if you really increase your irradiance power a lot, your effect might not be the same. So what happens is that when the intensity of the UV light is actually so high, it doesn't go so far, it's actually very shallow. So we usually measure our outcome and measure the effect or the result of the UV by looking at the demarcation line. So the protocols we discussed that. So the baseline values, you can see them here. The typical parameters that we use to study and just the outcome in any case of cross-linking. You're looking at the visual acuity, the spherical equivalent, the pachymetry readings, and the Kmax, and the elevation maps. So in all 3 protocols, you can see that they're all quite equivalent in results. Okay, let's skip the epithelium on technique or the transepithelial technique. I'm going to just rush and just try to save time on some of these slides so that we can just get the majority out of the slides without having any further interruptions from the connection. So just with the transepithelial technique, and this technique, of course, this technique is not favorable. It's favored in pediatric age group because of the issues with the epithelial healing and the risk of infection when you have an epithelial defect. But the efficacy of this treatment, because of the issue with the riboflavin absorption, is actually not good. Demarcation line is at 150 to 200. Usually our demarcation line in the standard or the accelerated or the epithelial off techniques is around 300 micrometers depth. In the epithelial or transepithelial technique, you have it at 150 to 200 microns, which is quite shallow. And usually in some case scenarios, actually these patients, sometimes they can regress if you do the epithelial on technique. Another thing is they try to find ways to improve the penetration of riboflavin, because this is a major problem here. And they found that using benzyl conium chloride and EDTA, they weaken the epithelial tight junction and allow better absorption. So these assisted techniques, while keeping the epithelium, they improve actually the efficacy of cross-linking. They are not as good as the standard or the epithelial off technique, but they are better than just purely epithelial on. And this is what happens. You just put the riboflavin after you put the enhancers, and you can see that the absorption is a lot better. Another way is to use the interferesis, which basically is used because riboflavin is a negatively charged molecule. So it's a good candidate for this kind of process. And what happens here, just go through the picture, it's better. You can see there's a positive electrode and power supply, and there's a negative electrode. And then you put the riboflavin, which is also negatively charged. And this just pushes the riboflavin through the epithelium and into the stroma. And again, this gives better effect than transepithelial alone. I'll skip all of this. So I just want to elaborate one thing regarding the safety process, or the safety cutoff limit of 400 microns. It's there. Why? Because if you look at the conventional protocol, the demarcation line, which is the expected effect, is at 300 microns of the stroma. And as you go deeper in the stroma, if you opt to treat a cornea that is less than 400, meaning that your residual stromal bed is, thinner than what they are recommending, it means that there is a higher chance for endothelial cytotoxicity threshold from the 0.35 milliwatt per centimeter that is going to reach the endothelium. So this level of toxicity is reached once this safety margin is, crossed. There's some protocols that are used for thin corneas, and I think this is the area where really I would like to talk about. So in cases, now we looked at the epithelial off techniques, we looked at when you have a transepithelial situation. When you encounter a thin cornea, is it a no-no to do the cross-linking, or are there options? Obviously, there are options. The first option, which is something I'm sure many of you heard of, is contact-assisted cross-linking. So you just basically remove the epithelium, place the contact lens on top, just to provide that extra, space or thickening, so that you provide that artificially extra tissue, just to spare the endothelium from harm and damage. Another way is to use the hyposmolar riboflavin. Another technique is to keep the epithelium on, what we just discussed a minute ago, and try to use enhancers just to improve your outcome. Another way that has been described is the lenticule-assisted cross-linking. This is for patients who are doing the SMILE procedure. There is also the customized epithelial debridement technique, where you remove the epithelium all over the cornea, but you leave just the epithelium at the cone, at the thinnest location per your topography map. And by that, you just, you're leaving, that extra space or extra thickness, just to preserve, that safety margin. And then you have the sub 400 protocol, or the customized or individualized cross-linking, which was described by Hafizi, and it's individualized per patient. So this is when you have the contact lens. Basically, you have this artificially additional thickness or space, just to add some width and avoid endothelial irradiation. When you're using the other technique is the hyposmolar riboflavin. I just wanted to elaborate a bit, just to give you an idea about the effect of this hyposmolar riboflavin fluid on the cornea. So the cornea has a tendency, or can swell up to double its size or double its thickness. But usually, this is in in experimental corneas. But when you're actually doing it, what the practitioners have actually calculated is around a thickness of around 36 to 100 microns increase in thickness. And how you do it is just apply the riboflavin without any dextran every 20 seconds for 5 minutes, and then you recheck, and then you repeat, and then you recheck until you get the optimal thickness. And this is the hyposmolar lenticule assisted. So this is basically when you do the SMILE incision, smile technique, sorry, and you remove this lenticule. Okay, and then what you do with this lenticule, you basically put it on top after you remove the epithelium, and basically you have this, extra stromal tissue on top, so that when you place the riboflavin and you place your treatment, you will, spare the endothelium the risk of damage. Now for the individualized corneal cross-linking technique, or the sub-400 protocol, which is described by Hafidi. So how do they do it? They do it, it's a pretty simple technique. It's mainly dependent on the algorithm that they had, calculated and just labeled in a table. So epithelium is removed, and then you soak the cornea with the riboflavin. Okay, it's a sodium editate, trimethyl enriched riboflavin, and it's in a hypotonic solution. And then you check for 20 minutes, and then you check your ultrasound pachymetry. And when you check your ultrasound pachymetry, you have to make sure that really you are rinsing the cornea before you check the calculation, because this thickness that you get, you're going to have to put it in the table, and then it will give you the amount of how much you will treat the patient. And the aim of this, what Hafidi was, trying to do, is keeping a 70 millimeter above the corneal endothelium demarcation line. So this is what he had calculated, and you can see here that they kept the irradiation fixed. So they kept it as the standard, which is 3 milliwatt per centimeter square. And what they had adjusted in their algorithm based on the thickness of the cornea that you have is the timing. So the duration is what's going to be different based on your corneal thickness. And they use the Schwind machine at 365 nanometers. And this is the algorithm, this is the table. So the minimum thickness that you can do this procedure on is 200 micrometers depth or thickness, sorry. So if you have a 200 micrometer thickness cornea, you're going to treat it for 1 minute, okay, at an irradiance of 3 milliwatt per centimeter square. So it's all fixed, 3 milliwatt per centimeter square. The difference is only in the duration, the timing, how much you will keep the irradiation. And this is the expected demarcation line where it will appear. And you can see here, you have 3 different cornea thicknesses that have all been treated based on the algorithm. You can see this is quite a thin cornea. I think this is around 250 micrometers thickness cornea. And you can see that the demarcation line here is 90 micrometers above the endothelium. And here you have a bit thicker cornea here, and here more thick cornea. Okay. So the cross-linking plus is basically when you do cross-linking plus photorefractive surgery or PTK, or photorefractive surgery or PTK. And the whole aim in this procedure in keratoconus eyes is just to improve, the high order operation, just to regularize the cornea and improve some of the refractive outcomes in these keratoconic eyes. I just wanted to raise here the question whether to do the cross-linking and the PRK, such as what is described in the Athens protocol, on the same day, or you want to do it sequential. Well, the results are variable, but many studies support doing it on the same day. But they found that many of the parametrics that are studied are a little bit better when you do it on site or simultaneously. Another issue or special situation is when you do the cross-linking and you have a LASIK flap. So what's best? Do you do the standard cross-linking on top of the LASIK, or do you lift the flap and you do the cross-linking under the flap? Well, if you do it as a regular case, then you have, good anterior cornea stiffening compared to the flap cross-linking technique where you lift the flap and then you do the cross-linking. But there is, the stiffening effect of the middle and the posterior cornea in each case unfortunately, both of them, they have minimal effect on the posterior aspect. So this is, not something, not a great thing to deal with when you have a patient who's post LASIK ectasia. But this is something, you have to keep in mind that the standard will give great stiffening of the anterior cornea, and the flap cross-linking, I think neither anterior and even the posterior has minimal stiffening effect.
Dr. Norah,
يا دكتور ماجد.
sorry to interrupt you. What do you think? It's almost 3 p.m.
أيوة خلاص. Okay, so I'll conclude here with this last slide. So corneal cross-linking in pediatric age group. We know that pediatric age groups are, are a risky group, and they have the tendency to progress. The only thing I want to say here is that you can use the standard or the accelerated protocols. Both protocols patients usually do well. Of course, they need, extensive monitoring these pediatric patients, but both protocols do well. The transepithelial, though, it has the advantage of, avoiding the epithelial defect and the problems with that. You can either apply the enhancers, okay, to get a better effect. Even with that, it's not as good as the previous two protocols. So I have a couple of slides left, but I think we can stop here and just stop here.
Allah يعطيك العافية. Thank you so much, Dr. Norah F.AlKhereigi. I want, huh?
تفضل دكتور ماجد. Go ahead.
Yeah, I just want to inform everyone that Dr. F.AlKhereigi just recovered from upper respiratory tract infection. فيعطيها الصحة والعافية that she was able to give the talk for 1 hour. And it was a nice review of the basic science behind corneal cross-linking. Please, if you have any question, feel free to contact Dr. F.AlKhereigi directly. We will post her email address in the chat box. Again, thank you everyone for attending, and thank you, Dr. F.AlKhereigi, for the nice review.
الله يعطيك العافية. Thank you, Dr. Majid. I wished, I had given it a better circumstance, but you have to do what you have to do. I hope that it wasn't too disturbing to bear